May I invite our first speaker, Dr. Chaitra Jayadev. Dr. Chaitra is the head of Retina Services at Narayan Netralaya, and she will be giving us an essential overview on screening of peripheral retina in refractive disorders. Thank you so much for joining us, Dr. Jayadev.
Thank you, Mudit, for that kind introduction. Let's kick off. Thanks to AIOS for this opportunity. I'm going to speak on a very important topic, and especially so for general ophthalmologists and also for those doctors who advise patients for refractive surgery, because these patients are expecting a 6/6 vision post-op, and you don't want to take any risk. There's a whole lot of medical legal issues involved with not achieving that goal for these particular patients. A lot of them are very young, so you don't want any trouble with respect to retinal disorders. So I'll be talking about peripheral retinal degeneration, when to treat these patients, and also the recommendation for patients undergoing refractive surgery per se. Now, let's understand the terminologies. What is degeneration? It's a loss of structure. And you know, in the retina, there's loss of structure, function of cells in the retinal tissue itself. And then you have peripheral retinal degenerations and macular degeneration, which does not come within the scope of this particular talk. We'll only be dealing with peripheral retinal degenerations. So this is a classification based on the location of the lesion. We look at vitreoretinal lesions such as snail track, lattice, retinal tears. Intraretinal, where you see retinoschisis, snowflake, and WWOP is so commonly noted. And then you have chorioretinal. But most important are these vitreoretinal, which is lattices and retinal tears that we're going to see. Why they're important? Because they're very anterior, even anterior to the equator. Most of us are not very comfortable doing IDO. Not all of us have access to wide field imaging, non-mydriatic imaging, and most of them can predispose to rhegmatogenous RD, especially post-operatively, and especially because these patients have a very, very high minus power. Now, what are the common and important ones? Snail track degeneration. Why you need to know this is because they are very similar to lattice degeneration. You need to make sure that you differentiate between these two, and even these can be associated with retinal holes, which is why they're very important. Next, if you see the OCT through that, you see an irregular retinal surface and hyperreflective dots, which are basically lipid deposits. These are not really important for the diagnosis, but just to give you an idea of how they appear. So here is the OCT through that retinal hole. You can even see a cuff of SRF there, which means you definitely need to treat these lesions. Now, these are the different vitreous changes that we see. Next is your lattice degeneration. I think most of you would have seen the cigar-shaped lesions. They could be single, they could be multiple, associated with holes or no holes. They can be even oriented along blood vessels, atypical. When you see patients with sticklers and marfans, they are quite atypical in nature. So these are the ones that I'm showing you. You see these arborizing lines. Some of them are pigmented and some of them are not. This is the vitreous changes that you see. You can see the vitreous condensation over the retina in these particular patients. Now, retinal holes, again, you can see atrophic holes, you can see operculated atrophic holes, and you can see even atrophic holes with a cuff of fluid. So all of them definitely need treatment because they are risk factors for retinal detachment. I've shown you all the three different types of retinal holes here. Now, retinal tear. Now, this is important because it's a very dynamic, lesion, which means there's an ongoing traction in these patients, which means you have to follow them up very closely and you need to treat them. There you can see the horseshoe shaped tear. This is not associated with the rhegmatogenous RD as yet, but big risk factor because there's a constant traction on the HST. Then you have the snowflake degeneration. This is innocuous, but you do see them in clinical practice. You just need to be aware of them. Paving stone, again, sometimes why I put up this is sometimes you mistake it for laser marks. So please be aware that these look like paving stone degeneration and this is not laser marks, and patient gets alarmed, like, why are you saying laser? I've not done, do I need laser? So it adds to the confusion. Good to remember it as a differential diagnosis. White without pressure, as the name suggests, it appears white even without causing the indentation. Normally with indentation you see it, but here you can see very clearly the white without pressure there. Very rarely is it associated with GRTs or giant retinal tears, so you may need to keep a close watch on them, especially post-operatively. So what causes RD? You have peripheral retinal degeneration, you're seeing a retinal detachment. What is the predecessor to this? It is basically a posterior vitreous detachment, especially when the vitreous is attached very tightly to any of these lesions. During the detachment or posterior vitreous detachment, which can occur normally, it can pull on these degeneration and give rise to a retinal detachment. So that comes to this symptomatic PVD that patients come to you. They say flashes or floaters. They can also see vitreous hemorrhage. You can see tears or even a retinal detachment very early in the course. But you need to repeat the examination 4 to 6 weeks later, especially if you don't see any lesions, because the PVD can take that long to complete its process. And when you see PVD with hemorrhage or pigments, more likely to have developed a retinal tear. So you have to wait for the hemorrhage to resolve and laser these patients as soon as possible. So when do you treat these patients? Let's look at an example. 26-year-old female, she comes for a routine checkup. You see that lattice there. Would you treat her? Show of hands. Would you treat her, Mudit? Just a lattice degeneration, no hole there. Patient has come for a routine examination, no symptoms, no family history. Then that's right. You don't really need to treat every single patient with lattice degeneration. But if she wants to undergo a refractive surgery, she's a high myope, she has a family history, there's a hole there, then you definitely want to treat this patient, because you'll never know what is the post-operatively. Unfortunately, what happens is most of these patients, once they undergo refractive surgery, they think that their retina also has become normal. So they don't come for a checkup. Especially if you're suspecting that this is going to happen with that particular patient, it's best that you treat them. Most of them travel abroad and come back after 3-4 years. So you want to make sure that they're safe. We don't have uniform guidelines to treat these sort of patients, because most of them are, Western-based studies, but there are medical legal issues, and we need to be extremely careful for our patients. And do not take into account different clinical situations. You have to consider family history, previous history, refractive error, which surgical procedure. All of them are important. So what is the lesion? What are the vitreous changes surrounding that lesion? And what are the risk factors? So this would be a stepwise approach to these patients. Now, recommendations for screening and management. Should we treat all lesions? Let's look at our data. Between 2020 and 2021, we saw 3,000 patients undergoing refractive surgery. Lattices was present only in 285 patients. Laser was done only for 94 of them and not done for 191 patients. None of them developed retinal detachment. So are we erring on the side of caution? In fact, for a patient who didn't have lattice, developed RT. So I think we are being overcautious, but I don't think it's a bad thing, because you don't want to fight this in the court of law. So no RD again in these patients who even underwent laser. So recommendations, please note this: treat properly all symptomatic, asymptomatic horseshoe tears, operculated holes, lattice with holes, and atrophic holes. These are mandatory treatment lesions. Others are recommended. You can base it on the other risk factors that I spoke about, like family history, refractive error, previous detachment in the other eye. All those things you need to take into consideration. So like I said, this is the ones that you need to treat promptly, with or without patient undergoing refractive surgery. Patient might say, I'll come back for laser when I'm undergoing refractive surgery. No. And most of them get confused that this laser is the same as refractive surgery. Again, you have to be very, very careful about that. When is the timing? Ideally, you have to do it after at least 7 to 14 days, because that's how long the photocoagulation takes. And re-examine the patient 2 weeks post-surgery, preferably. And studies have shown that the lesion, if a new one occurs, it's usually in the same quadrant as the previous lesion. Who should do the screening? Anyone who's comfortable doing a retinal examination. Use wide field imaging. If not comfortable, refer to a retina specialist. So to conclude, patients undergoing refractive surgery needs a thorough retinal examination, barrage laser whenever possible, and you should tell these people, impress upon them that you need to come back for a retina checkup, if not going to the refractive surgery department. Thank you so much.
Before we move on to the next speaker, just one question. So essentially, for all refractive surgery, if the patient is planning to go ahead and you see a lesion, you go ahead and advise a laser.
Yes, mic, it's not on, I think.
So the question is that for all patients who are planning to undergo a subsequent refractive surgery, you will advise for a prophylactic laser for any peripheral retinal lesion.
I also want to add that my threshold is a little lesser for refractive laser refractive. But for those who are going lens-based, like these phakic IOLs, there I tend to be a little bit more aggressive in advising, because I've seen more tears and breaks after phakic IOLs than with...
the other reason is that phakic IOLs predominantly are done more in very high myopes.
Exactly.
So the vitreous changes are much more in those eyes.
Yes.
And the detachment also are more difficult to treat for these eyes.
Absolutely. Absolutely.
All right. So thank you so much for that.
Thank you. I need to leave for another session. So thanks for the opportunity.